we are here to have a discussion on latest update in the hypertension. So as per World Health Organization, nearly 63% of the total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects 45% of the people in the age group of 40 to 69. Raised blood pressure is among the most important risk factor for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over the 30 years to 38% in men and 32% in females, from 29 and 28% respectively. Despite that, nearly half of the people, or 51% of the men and 41% of the women with hypertension, were unaware of their condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 out of 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings. Optimal care refers to evidence-based standard of care, and where essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The American Heart Association or American College of Cardiology has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low risk adults, no associated cardiovascular disease or 10 years CVD risk of less than 10%, with stage 1 hypertension, that is blood pressure of 130 to 139 systolic and 80 to 89 of diastolic. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. Acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study, which appears in the Journal of the American College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Another is lowering systolic blood pressure targets down to the 110 to less than 130 mm mercury range substantially reduce cardiovascular adverse effects in the STEP randomized trial, affirming the SPRINT findings for an older Chinese population. Among some 8,500 patients ages 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies ranges from threshold of 130 to 150 millimeter mercury. Next, with regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office BP measurement but also on out-of-office measurement such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24 hours and nighttime BP measurement were associated with greater risk of mortality and a composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurement for estimating cardiovascular risk. For every 20 by 10 millimeter increment of BP measured at night, the risk of mortality increases by 23% and the risk of cardiovascular damage increases by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitors or ARBs plus calcium channel blocker or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitrosodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA containing contaminated valsartan from Zhejiang, Hubei every day for 6 years, the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily doses for over even 4 years. Valsartan, recall, accompanied by a significant increase in the rate of emergency department visits of more than 6%. The HYGA study represents the largest study that nested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary cardiovascular outcome. An ambulatory BP measurement performed for 48 hours to collect data on how BP different during sleep. The RR reduction for cardiovascular event was significantly improved for nighttime treatment when compared with awakening treatment. With this, I come to the end of the talk. Thank you.